A very good morning to faculty and colleagues who've joined us from the United States. A very good afternoon to our presenter and viewers from Africa and European countries, and a very good evening to friends and participants from Asian subcontinent. Today, we are privileged to have with us prominent faculty, or if I may say, doyens in the field of obesity, for leading this 11th Endotext webinar on obesity. Endotext, as we all know, is a famous online PubMed index textbook, widely used both by faculty and students throughout the world, even widely used in India, a ready reckoner for immediate reference seeking for getting details of disorders related to endocrinology. So today, we are privileged to have with us 2 speakers and 3 chairpersons. I will take the opportunity to share my screen and briefly introduce our chairpersons and speakers for the day. Our first chairperson is Professor Jonathan Purnell. Sir is a professor of medicine at the Oregon Health and Science University, and also at the Knight Cardiovascular Institute and the Division of Endocrinology. So is also the Associate Director at the Bob and Charlie Moore Institute for Nutrition and Wellness. He's a physician scientist focusing research on understanding the causes and consequences of obesity, metabolic syndrome, dyslipidemia, and diabetes in humans. Dr. Purnell is a member of prestigious societies, including the American Physiology Society, the Endocrine Society, the Obesity Society, and the American Federation of Medical Research, as well as the ADA. We welcome you, sir, and we are privileged to have you amongst us today. We also welcome to have with us Professor Blandine Laferriere. Dr. Blandine is a professor of medicine at the Columbia University, a full-time attending physician in the Division of Endocrinology. She's a board-certified endocrinologist. She has dedicated her research career on endocrine aspects of obesity and type 2 diabetes, first working on regulation of leptin and ghrelin, and now more recently moved towards the work on incretin hormones as possible mechanisms of glucose control after bariatric surgery. Dr. Blandine is also the director of the Translational Biomarker Core of the Columbia Diabetes Research Center. She's been the principal investigator of the 2 landmark studies, the Diabetes Prevention Program Outcome Study, as well as the Look Ahead Study, and also a visiting faculty in France. Welcome you, Professor Blandine. We also have amongst us 2 case presenters who are emerging endocrinologists faculty. One is Dr. Aramide Adideran. She's a consultant endocrinologist and a chief medical officer at the General Hospital in Efako, Lagos. In the past, she's worked as a senior registrar in endocrinology at the General Hospital in Lagos and has done her endocrinology and from the National Postgraduate Medical College in Ijanikin, Lagos. Hobbies include watching movies and reading. And we also welcome Dr. Kalyani Sridharan. She's an assistant professor of endocrinology at AIIMS Rishikesh, having completed her fellowship and super specialty training in endocrinology from the famous Jipmer Institute in Pondicherry in 2018, and has several publications in national and international journals. So we are privileged to have star-studded faculty today. I am Dr. Nitin Kapoor. I'm an endocrinologist based at Christian Medical College, Vellore in Tamil Nadu. So with the permission of the chairpersons, I would like you to please give a brief welcome note, and then we would request Dr. Kalyani to present her case. May I request Professor Jonathan Purnell to please say a few words before we start?
Thank you very much. It's a privilege to be here with you and to participate in today's discussions. I'm very much looking forward to it. Thank you.
Thank you, sir. May I request Professor Blandine to please say a few words? Ma'am, we cannot hear.
Sorry, I was muted, sorry. Thank you very much for the nice introductions, and I'm also very pleased to join this interesting discussion and looking forward to it. Thank you very much to the organizers.
Welcome, ma'am. And sir, may I request Dr. Kalyani to please present with the first case?
Good evening, everyone. It's a pleasure to be a part of this the session you're having today. I'll just present the first case. I'll right now share my screens, and then we can, I'll just discuss the case, and then have questions and discussion as I move along. Is my screen visible?
Yes.
Right. So I'll be discussing today a case of morbid obesity, which is complicated with an endocrine condition. So this is a 28-year-old lady who presented to us first with symptoms of weight gain and irregular menstrual cycles. This history of weight gain dated back 6 years, and it started soon after her second delivery, with, at which point she gained around 33 kgs from 87 kilograms to 115 kgs. In addition to weight gain, she also noted hirsutism, easy bruisability, irregular menstrual cycles, and facial puffiness. She also has a history of hypertension for the past 5 years. There was no history of intake of exogenous steroids of any sort, no history of diabetes, obstructive sleep apnea, or osteoarthritis. This is the clinical photographs of the patient. As you can see, in 2006, this was a photograph that she provided to us. And around 8 years later, what you can see is the obvious facial rounding. There is a definite facial plethora around here. And also what is more obvious also is the acne here. So when we examined her, she had a height of 160 centimeters, weight of 115, a BMI came out to be 44.9 kg per meter square. She was having hypertension with a blood pressure of 150 upon 100. There was acanthosis nigricans. She had a dorsocervical pad of fat, purplish abdominal striae, moon facies was present. There was, however, no pallor, icterus, cyanosis, clubbing, or pedal edema. Modified Ferriman-Galloway score was around 11 on 30. So, Professor Nitin, a question to you as we go along. How in clinical practice would you differentiate a patient with constitutional obesity versus a patient with Cushing syndrome?
Thank you, Dr. Kalyani. And I think this is a very common clinical problem that we encounter in our day-to-day practice. Many times patients with obesity, they may appear Cushingoid, they may have few features of Cushing's, but may actually be pseudo-Cushing. So in clinical practice, we have certain features which help us differentiate whether the patient actually has endogenous Cushing's or it is just severe obesity. And these are known as the discriminatory features of Cushing's. A few of the important ones include proximal myopathy, that is weakness of the proximal muscles. A common question that you can ask to your patients is difficulty in climbing stairs, difficulty in getting up from a squatting position or getting up from the chair without support. You can often demonstrate this in your practice, in your clinic. The other important thing would be easy bruisability. Patients would also come back and tell you that, doctor, whenever blood is taken for a sample, blood sample, there's often a big bruise there, or if there's minor trauma, there are different blotches on the skin. Presence of striae, abdominal striae, which are usually more than 1 centimeters in width, often non-tapering, could also point towards presence of Cushing syndrome. Presence of a facial plethora. Now, facial plethora is commonly seen in people who have a light colored skin, may be difficult sometimes in those who are from the Asian or the African descent, but is also an important discriminatory feature. And the last one that I'd like to mention is sometimes hypertension, which is often uncontrolled at a young age, would also point towards Cushing syndrome. So these are clinical features, but on biochemistry, if you alongside also have hypokalemia, hypokalemic alkalosis, that is something that will point towards Cushing's. And obviously, if you have a suspicion, there is no harm to rule it out. You would like to rule out an exogenous intake of steroids first by measuring an ATM cortisol and go ahead with the standard screening test for Cushing's if there is a strong suspect. But the key important features that you need to remember in clinical practice include proximal myopathy, presence of purplish white striae, easy bruisability, facial plethora, and striae. Thank you.
Right, sir.
If I might say something for a moment, since we're here on behalf of Endotext, in our obesity section, there is a chapter on the lipodystrophies. These are conditions where patients lose fat, ability to deposit fat in certain parts of their bodies, like arms and legs, and then that becomes more concentrated in other parts of the body. And they can look exactly like they have Cushing syndrome because they have the buffalo hump, the moon facies, the central distribution of weight, and skinny arms and legs. It's an excellent chapter. I recommend it because there are different types of lipodystrophies depending on where they are and how much there is. So just putting a plug in there for that chapter online.
Sure, definitely, sir. So let's move on to the next question. I have the next question for Professor Blandine here. Ma'am, how would you consider a polycystic ovarian syndrome as a differential in this particular patient?
So this is a beautiful case. It's almost like a textbook case. So in a way, you know, it's sort of give the punchline when you just present your case about Cushing. I just want to point out that, you know, obesity and serious obesity, like this woman has, is extremely common, and Cushing is very rare. PCOS is kind of a, you know, mixed bag of stuff that we put in when we don't find anything else. It's also a fairly common disorder, and you know, insulin resistance is at the core of it. So it's definitely in the differential here, although, you know, some features of your case really point out to Cushing, even without looking at a photo of your patients, because she's very young and everything happened within like 5 years. She had previously a very well-functioning gonadal axis because she had 2 pregnancies. So suddenly she had those menstrual irregularities, the hypertension, the hirsutism. So everything is happening at once. And she's 28. So this is really pointing out to that. So I think PCOS is there, but to me, it's, you know, I would first, of course, rule out Cushing in that particular case.
Right. Thank you, ma'am. My next question to Professor Panel. So what investigations would you like to order for this patient as we proceed with the case?
So you have several different options, but I'll tell you the one that I prefer is a 24-hour urine collection for free cortisol and creatinine. And that will allow you to sort of investigate over the 24 hours. 2 other options available to you would be to do an overnight dexamethasone suppression test. In that situation, it's not my first preference because the possibility of the higher plasma volume dilution of the dexamethasone. It's 1 milligram at 11 o'clock at night, followed by an AM cortisol the next day, typically in our hands at 8 a.m. It's best to obtain a plasma dexamethasone level to make sure that they're not a fast metabolizer and give you a false positive in that situation, and that they took the tablet and so on. But because of the dilutional effect, I prefer the 24-hour urine cortisol. Another option is to get either blood or salivary cortisols at midnight or around 2 a.m. One of the hallmark biochemical abnormalities of Cushing syndrome and I'm sorry, I didn't say that I'm trying to rule out Cushing syndrome in this patient, which I agree with the other discussants is very likely. But one of the hallmark abnormalities of hypercortisolemia associated with Cushing syndrome is a loss of the diurnal pattern. Normally, we have undetectable levels of cortisol at midnight to 2 a.m., but you can actually simply lose the diurnal pattern through continuous secretion of cortisol, and you can have a Cushing's phenotype. You don't have to have an elevated 24-hour urine cortisol. You don't have to have a failure on the suppression. Just the loss of the diurnal pattern can do that. So those are the 3 things that I would do. I'd also make sure, I don't remember if you told me, but I'd get an A1C and a lipid panel on her too, and a thyroid study. Electrolytes would help determine the severity if there is a mineralocorticoid effect that she's experiencing. That would be it.
Right, sir. So let me proceed with the case and look at what we have done. So as Professor Panel said, we almost did all that he said. There was an elevated 24-hour urinary free cortisol. This is in all the units are in microgram per DL. The basal values came out to be 1281. Her baseline 8 a.m. cortisol was 24 microgram per DL, there was loss of diurnal rhythm, with the midnight cortisol being 26.6 microgram per DL. And on dexamethasone suppression, on a 2-day dexamethasone, that's a low-dose dexamethasone suppression, she did not suppress her serum cortisol, which remained elevated at 18.47. And the high-dose dexamethasone suppression also, however, there was a more than 50% suppression on the HTTST, that is the high-dose dexamethasone suppression. So, so this establishes hypercortisolism, as Professor Panel just pointed out. And in addition, to know if it's ACTH dependent or not, we did a serum 8 AM ACTH, which was elevated at 396 picogram per DL. So this basically established the diagnosis of ACTH dependent hypercortisolism, and likely a pituitary source because the HGST was suppressed, and that's the most common source. In addition, on other biochemical investigation, the patient was found to have diabetes mellitus, dyslipidemia, and vitamin D deficiency. So we went ahead, and because the results suggested a pituitary source, we got an MRI of her pituitary done. And this showed, as you can see, an adenoma here on the left side of the pituitary. And she went ahead with endoscopic transphenodal excision of the pituitary microadenoma in 2013. So on histopathology, the tumor showed sheets of medium-sized cells with abundant cytoplasm and oval nuclei with evenly dispersed chromatin. The tumor cells was immunopositive for ACTH and cytokeratin, and negative for all other pituitary hormone markers. Crookes Highline change was seen, and the MIB labeling index was between 3 to 4%. And the nuclei were negative for P53. So the report was atypical ACTH producing pituitary adenoma. It doesn't go with the latest WHO histopathology, but considering the mitotic index, and it was and the MIB index of 3 to 4%, it was an atypical ACTH producing pituitary adenoma. So following surgery, the patient, her post-op cortisol values on day 1 was 0.9 at 8 AM. So that qualified for an early remission. She went into a biochemical remission for Cushing's in the post-op period, and she required steroids. There was a patient, she did well. She lost around 11 kgs in the next 3 months. Her weight came down to 104 from the previous pre-op 115 kilograms. BMI came down to 40.6, and however, the blood pressure stayed at 150 on 100. And she persisted to have diabetes, hypertension, and dyslipidemia, and she required treatment for the same. And however, she started to have her cycles again, and which were regular now, and her A1C was at 8.1. So, Dr. Nitin, would you comment on the MRI that I just showed you, and what would be the cure rates following a transphenodal surgery for a patient with Cushing's disease, like in this case?
Thank you, Kalyani. And yes, the classical teaching for patients with Cushing's disease, what we know from literature, the most common cause is a microadenoma. And when we say it's a microadenoma, the size is often less than 10 millimeters. And in this particular MRI, probably, I'm not sure of the size, but then maybe around 10 millimeters is probable, because you mentioned it's microadenoma, but it looked a bit large. So maybe around just there, a microadenoma. There. So 90% of Cushing's disease is essentially because of microadenoma. This one is a very clearly seen tumor on the left side of the cella, but then in other tumors, or many times in practice, we don't get such discrete tumors. And what we do usually is a dynamic cut or a dynamic imaging of pituitary sections, wherein we're just focusing at one particular cut at different time points by infusing contrast. And usually the pituitary would take up first, and then the later part of the tumor would take up, and therefore that can be visualized. Well, talking about the remission rates, now again, it would depend whether we're talking in terms of microadenoma or a macroadenoma. By literature, most microadenomas, what we would usually counsel our patients, it would be about 70 to 75% remission, whereas for macroadenomas, it's much less, about 45%. In our experience, paper published from our center, we had very similar rates, maybe about 75% for microadenomas, 55 for macroadenomas. But the macroadenomas that we see at our center is probably a larger proportion being a tertiary care referral center. But the key factors which will determine remission are not only the tumor size, but the invasion, and another important factor is the surgeon's experience and skill and in managing these kind of tumors.
Right, sir. Thank you. So I'll come back to Professor Blandine. Ma'am, what is your comment on the weight loss that follows the cure of Cushing's disease? What is the kind of pattern that you see, and how much weight would you expect following a cure?
So yeah, this is I think the interesting part of your case is that she has Cushing syndrome, very obvious and very well treated and worked up, but she also has, a morbid obesity in the background. So she's losing about 11 kilograms. And if you look at the literature, which is, there's not tons of literature, as Cushing is very rare, but this is about what people lose, about 10 kilograms. So she, this is what we could expect. She does remain severely, with severe obesity. So I know you have a question later on body composition, of this weight loss. So we can discuss that later. But I think her weight loss is expected. In that case, yeah.
Right. So, Professor Panel, could you comment on the medical management of diabetes in patients with obesity? How would it differ from patients without obesity, or does it affect the management of obesity per se?
Well, the typical distinction is between type 1 and type 2 diabetes. Obviously, she doesn't have type 1, she has type 2 diabetes. And in this scenario, the guidelines from the American Diabetes Association have changed in the last couple of years to really emphasize, they've always traditionally emphasized using management with metformin as a starting place, but they've shifted because of the beneficial outcomes on cardiorenal protection from SGLT2 inhibitors and GLP-1 receptor agonists towards introducing those medications next, as opposed to sulfonylureas or DPP4 inhibitors or even insulin. That A1C is perfectly within line of starting with metformin. And because of her severe obesity, I would probably, my next choice would be a GLP-1 receptor agonist. And the ones that have not only benefits on glucose control, but also weight management, which she would be a candidate for, would be something like semaglutide or liraglutide, in my experience, have a little bit better effect on weight loss. So my plan, though, for these patients is eventually I'm going to get them on all three, regardless of the A1C. So even if the A1C came down to 7.4%, and then with a GLP-1 receptor agonist, it got down below 7, I still would plan eventually to move forward with that.
So can I make a comment here? I just completely agree. We have a lot of great new drugs, on the market, although they might not be available on all insurance plans in the US and probably not in other parts of the world. I would definitely also emphasize lifestyle as a cornerstone of the treatment, with obesity and diabetes. There's the direct trial was done in the UK, showing that even in severe obesity with type 2 diabetes, you can reverse the diabetes entirely with a very low calorie diet, which is not necessarily what we want to do in clinical practice all the time, but just to emphasize that this is feasible and to encourage the patients to start working with lifestyle changes.
Right. All right, moving on with the case. So the patient was doing well. She had lost around 21 kgs in the first 1 year, but over the next 3 years, she began to significantly gain her weight again. She was around 94 kilograms in 2014, and the weight increased to 125 kilograms in 2017. And correspondingly, her BMI increased to 48.6 in 2017. Her blood pressure, she was still hypertensive at 150/90. Her repeated biochemical workup for Cushing's was negative. However, her diabetes, hypertension, and dyslipidemia were in poor control, with the A1C now rising to 9.6%. Again, Professor Panel, on the lines that you were just discussing, what is your experience with subcutaneous semaglutide in the management of obesity?
It works really well. It's very well tolerated by most patients. It's once a week administration. And if people do tolerate, so the main issue is nausea. And so we start off at a low dose, 0.25 milligrams here in the States, and go up slowly to the 1 milligram dose. The 2.4 milligram dose is under review now by our FDA panel. But when people respond to it, not everybody does, but when people respond to it, they're very happy and routinely lose on the order of 10% more weight, 10% weight loss with it. So I have been very pleased with its use. Plus you bring down the A1C. So at the same time, so I have had very good experiences with this medication.
Dr. Nitin, what is your experience with regard to intragastric balloons or other such devices for the management of obesity?
So we in India are still waiting for subcutaneous semaglutide. We've used it in clinical trial settings, but not in practice as of now. It's not yet launched. So we do use liraglutide, and that too not at 3 milligram doses, but lower on. So in that case, with very few medicines for medical management or weight loss, we do try other things, and this is something that we've started over the last 1 year here in CMC Vellore, the intragastric balloons. So the basic principle is many times these can be endoscopically placed, and they are kept for a period of around 6 months. The average weight loss that we've seen over a period of 6 months is about 15 to 20 kilograms. And it's important to know that when to put it. So whenever people have significant comorbidities and they're not fit for bariatric surgery, this is something that can help them. Sometimes even as a bridge to bariatric surgery, the classic indications would be for BMI between 30 to 40 kilogram per meter square. But sometimes people with morbid obesity, before bariatric surgery to help them lose some weight, this is helpful. As it's important to know the indications, I think it's equally important to stress the contraindications in anybody who's had previous gastric surgeries, problems like the hiatus hernia, and anybody with coagulation disorders, recent malignancy, alcohol abuse. And another important thing is severe liver disease. And especially with varices, this would be a contraindication. So we do use them for a period of 6 months. There is a weight loss of about 15 kilograms.
Right. Professor Blandine, what is the role of body composition assessment in the evaluation of obesity? So here is one where we did this in this patient. Could you just give us your views on how to interpret body composition analysis and its use in patients with obesity?
So that's a sort of a question that could be a sort of a webinar in itself. It's, I think it very much depends on the method that you're using. So what we do have in clinical practice, and I don't think it's any different in the US, from, what it is in India or Africa or Australia, is a tape measure, a scale, and a stadiometer. So calculating BMI and measuring waist circumference, I think those are very important. Doesn't, of course, tell you body composition. In terms of the methods, if you look at the literature, usually BIA and DEXA are sort of the most reported one. I think BIA is just not precise enough to be used in the context of obesity. And for example, in your Cushing patient, I don't think it would bring you information. And actually there's some data out there published showing that doesn't bring you enough information. The DEXA is interested for two reasons. It can give you both the body fat, if you do a total body DEXA, with some idea of the distribution of the fat, with some software giving you truncal fat versus peripheral fat. But most importantly, again, in the context of Cushing, it can give you bone density. One feature of Cushing is that those individuals with obesity actually have low bone density, which is opposite of what you would expect in someone with obesity, where they have actually increased bone density without the Cushing. So if I had to do one body composition in a patient with Cushing, perhaps also if the patient was a bit older, here your patient is 28, I would probably do a bone density to assess the effect on the bone of the Cushing disease. Often Cushing makes years to be diagnosed, and so patients have had exposure to high cortisol for a long time. So that would probably be the one that you could do and could probably get reimbursed by insurances. On a research setting, you could do many things. I was actually looking back at the literature, and in the 60s and 70s, people have published data with underwater weighing and total body water in Cushing patients before and after surgery. So what people lose, they lose essentially fat mass when they lose the weight after the treatment. And some of them, if the case is taken early enough, can actually have the body composition recover, if you want, to the level of someone pre-Cushing with the same level of obesity. So I think the hypercortisolism, and was pointed out before by one of the discussants, can give you sarcopenia and myopathy and decreased lean mass, both the bone and the muscles, and that's has some comorbidity. So I would look into that. An increase, of course, visceral fat and perhaps liver fat, and with the context of insulin resistance. So if you could do, a total body MRI, a CT scan of the abdomen to look at visceral fat and all of that, it would be wonderful, but that will be done in a research setting.
Landine, what do you think about the visceral fat measurements in the DEXA scans as shown here?
Well, it's an estimate, and I think it's a good attempt. And again, if you do a repeat study, it could be valuable. The problem also with DEXA, if you have, let's say, somebody who undergoes bariatric surgery, so like actually this patient, so they're going to lose 30%, 30% of the body weight. So then if you do the same DEXA on the same machine, there's lots of artifacts due to the depth of the fat tissue that I'm not even sure the software adjusts for. I've asked this question many times, years back when I was sort of doing some research, and it was not clear to me that you could actually get some very valuable data. It's indicative, and I think but I would not put my. I don't think it's as good, of course, as a CT scan, a slice of CT scan in the abdomen on L4, L5, or MRI.
Yeah, we had an opportunity a while back to actually compare the CT scan to the DEXA, and it wasn't too bad. But my conclusion was you needed several hundred people in a research program to really say if there's a difference in visceral fat between groups. It's not as precise. It doesn't have the precision that a CT scan has. I would say right. This DEXA scan also points out one of the problems of studying patients with severe obesity, which is they don't fit onto the table entirely. So you're actually missing some of the body composition in both arms. And one way that we get around that is to do a hemi-scan. Just scan half the body and double it. And that oftentimes gives you a pretty good estimate of the body composition too. But that'll change when they lose weight. So you'll be comparing, again, potentially, if you did a repeat of a DEXA scan, which I'm not necessarily recommending you do, you'd have to take that into account.
Right, sir. Looking at her present condition, we advised lifestyle modification. We added a meal replacement therapy to add to her weight loss. And as was suggested, we had added liraglutide, started with 0.6 milligrams and then escalated to 1.8 milligrams to her other anti-diabetic management. So over the next 6 months of this treatment, she lost around 3 kilograms. But again, she significantly had osteoarthritis, and she was finding it very difficult to continue her day-to-day activities. She was given options for bariatric surgery, and later she underwent a laparoscopic gastrectomy in 2017. Professor Panna, for students, again, I think what was already said. If not, I will proceed to the next question, sir.
I'm sorry, say that again. I had there's a lot of choppiness there.
Would you want to add anything about interpretation of the body composition report, or if not, I'll proceed to the next question, sir.
No, as you're probably aware, within the South Asian population, there's a recognized lower muscle mass proportion to fat mass already on average, actually seen all the way down into childhood, and a propensity for more visceral fat in this group anyway. You can, I don't know if you, I'm sorry if this is breaking up, but you can also pick up other metabolic footprints of visceral fat by looking for high triglycerides, low HDL, and type 2 diabetes. And that's also indicative of typically fatty liver at the same time. So you don't necessarily need the body composition to tell you the distribution of the fat typically. You can oftentimes do this with just simple lab work as well. I anticipate that if you were to do a follow-up DEXA scan with this, you would see, as Dr. LaFera said, a very large loss of fat mass, but you'd see a loss of the muscle mass too, as well, depending on how they're managed afterwards from a nutritional standpoint.
Right. Professor Blandin, again, what would be your comment on using this meal replacements like OptiFast for say 2 weeks before bariatric surgery? Do you use them regularly?
Yeah, so thanks for the question. I just want to go back to your case for a minute. I think it's very important for when you present an obesity case to add a little something about the common diet of the patient. And one differential that didn't come up in the discussion yet is alcoholism, and which could actually make your patient look like a Cushingoing, type of patient. So, and this patient, after she was cured from a Cushing, regained a lot of weight. So again, she has, propensity to become severely obese, and maybe she has, something there. But her diet is something that I would definitely emphasize, including with the GLP-1 agonist treatment, because it could help her a lot. So I would definitely do what I do is kind of a 24 diet recall. I ask the patient, what did you eat yesterday? And they always tell me, oh, yesterday was not typical, doc. I say, that's okay. Let's look at what you had yesterday, the time and the composition, and let's, we go over that. And of course, alcohol, juice, soda, are sort of big, okay. The second thing, in a young woman especially, and she regained very fast her weight after the Cushing treatment. I would look for depression, and I would screen for depression. I would also screen for food intake disorder. Because that could be a cause of, she could have the perfect diet, during the day, but she could be binging at night, or, she could have something that she's not telling us, or being very depressed. And that could be, if you don't treat that, that's not going to treat her obesity. And actually, she might not do that well after bariatric surgery either, if she has a food intake disorder. So I'm closing my parenthesis here, but I think it's important to recognize that. And, obesity is so prevalent. In the US, we have half of the adult population who has obesity. We cannot offer bariatric surgery or even medication to all of those people. We have to go with lifestyle. So I think it's important to focus on that. Now, let me answer your question about the bariatric surgery before I diverge too much. I think the surgeons are very eager to have a low-calorie diet by some meal replacement, which is something that's been demonstrated to work very well in a lot of randomized trials, in order to shrink the liver. The liver is usually very large in those patients, very hard to do the surgery. And so a very low calorie diet for just even a couple of weeks is extremely efficacious in shrinking the liver. And again, this was well demonstrated in the DIRECT trial. I would suggest that if needed, and most surgeons recommend it, I think it's okay. Now, someone who has type 2 diabetes, who might be on insulin, who might be on sulfonylureas or something, of course, you have to warn them about hypoglycemia and watch them very carefully for that.
Right. Dr. Nitin, what is the role, as Professor Blandin was just mentioning, the importance of focusing on psychiatric aspects like depression. So what is your experience and the role of psychological evaluation prior to bariatric surgery?
So thank you, Kalyani, and completely agree to what has been said. And I would say that often the relation is bidirectional. It's not only obesity that can sometimes lead on to depression, but depression itself can also cause a lot of binge eating and obesity. So it's bidirectional. We here in our obesity clinic have a full-time psychiatrist. All patients are screened by the psychiatrist. And what we found is that about 30% of people with morbid obesity that we see in our clinic actually have an underlying psychological problem. Most common one being depression. Some of them have anxiety disorders. But again, even in those small proportion, eating disorders have to be ruled out. And as was mentioned, what we really see more commonly is something called as the night eating syndrome. And even if patients are not eating a lot during the day, sometimes they binge eat a lot at night. Another important aspect is that sometimes we have to also rule out certain cognitive and psychotic disorders, especially if you're subjecting the patient to bariatric surgery. This needs to be ruled out. And a more recent concept that's coming up in a big way is looking at food as an addiction disorder, and a lot of principles that are being practiced with respect.
Dr. Nitin, we're losing out on your voice.
It looks like he froze. While we're waiting for him to come back, you there?
Yes, sir. We can hear you.
Okay. In the old days, like 20 years ago, the psychological evaluation was to try to identify eating behaviors or the root causes of eating behaviors that were thought to contribute to the obesity. And since we now understand obesity as a chronic disease and has hormonal and biological underpinnings, we now recognize that many of these behaviors we see are actually driven by internal biological signals. So like when people put down a fork is influenced by satiety signals created as we eat a meal. When we go look for food, type things are driven by hunger signals. The most notable one is ghrelin. But in our experience now, so we no longer necessarily use the psychological evaluation as a tool to identify some missed psychological diagnosis, but also to prepare the patient for what their life will be like after the surgery. Because there's oftentimes, we do it for health reasons, but because of the social stigma associated with obesity, there's so many psychological ramifications of that patients aren't necessarily prepared for. Sometimes, we know that there is bias against obese patients with regard to job hiring, pay disparity. They are less likely to be married. Their incomes are lower. So some people might think, oh, I'm going to suddenly go through the surgery, lose this weight, and I'm going to get married, and I'm going to have kids, and I'm going to get that job, and people are going to like me. And it actually can have the opposite effect sometimes, where they realize how much they were discriminated against, or people felt about them, and it angers them because they're not any different as a people. They're just different from what they appear on the outside. They're healthier for sure. So it actually can be sort of what I call an unintended consequence. We have an improvement in health, but potentially someone who's not prepared for where their expectations for what their life will be like doesn't match with what happens to them. So I think it's a very important thing to do, although not necessarily for what it was originally intended for 20 years ago.
Right. Yes, sir. Following up on this patient, she was doing well. She had lost around 22 kilograms in the first year following the bariatric surgery. Her current weight after the weight gain in 2017 was around 105 in 2018. And so BMI subsequently fell from 49.6 to 41.1. Blood pressure stayed at 150/90. Her repeated workup, biochemical workup for Cushing's remained negative. Her hypertension and dyslipidemia were under poor control. However, she was off anti-diabetic medication and her A1C came down to 6.6 from 9.1. So at second year of follow-up, she had totally lost around 27 kilograms after the from the pre-operative weight, and the BMI fell below 40 to 39. Hypertension and dyslipidemia were now well controlled. I think this is I'm sorry, a wrong blood pressure value here. She was off anti-diabetic medication and her A1C stayed at 6.4. So, Professor Blandin, what is your comments or thoughts on the reversal of diabetes following management of obesity? That is bariatric surgery versus lifestyle alone.
That's a great question, which has been an interest of mine for many years. So it's it's the extraordinary effect of weight loss on treatment of type 2 diabetes. So that comes back to my lifestyle, the role of lifestyle intervention in type 2 diabetes. And we have, in terms of large lifestyle trials, we have the Look Ahead trial in people with type 2 diabetes that showed that you could actually improve diabetes with a 7% weight loss. And this has been reproduced in various continents, so very important. In terms of the full reversal of diabetes, like, remission of type 2 diabetes, like your patient, no medication and semi-normal hemoglobin A1C, or borderline, in the 6% range, which we will all be very happy with. This is, the dramatic effect of bariatric surgery, especially gastric bypass surgery. And we think that in addition to the tremendous weight loss, which after bariatric surgery, usually 20 to 30% weight loss, so a large magnitude of weight loss and often sustained over time for most patients, which is the main mechanism by which diabetes goes away. And again, that's because we also have other lifestyle trial with lesser weight loss, 7%, but also the direct trial done in the UK in primary care practices, showing that with a VLCD diet and with people losing the same amount that they would lose with bariatric surgery, you can actually reverse the diabetes entirely. Now, this being said, people who have advanced diabetes, so long duration of type 2 diabetes, poorly controlled, on insulin, and for many years, even if they lose a lot of weight, that's going to improve their insulin sensitivity for sure, but the beta cell function defect might not go away. So those people might get off the insulin, they might improve their control, but eventually they might, request some medications and then maybe more medications over time. So that means that we need to follow those patients after the surgery for many years. Number one, we also need to reset the expectations for them. Tell them that diabetes will improve, might go away for a few years, but might come back. So they still need to be, they're in remission. It's not a cure of type 2 diabetes.
Right.
I hope that answers your question.
Yes. Dr. Nitin, are you there?
Yeah.
Yes. What would be the role of genetic evaluation in a case of young onset morbid obesity?
Right. So, if you look at worldwide literature, genetic or specifically monogenic causes of obesity forms a very minor component of the general obesity or the usual obesity that we see in our clinics. But what is important here to remember is that there may be ethnic differences here. Now, in countries like India or some of the South Asian countries, there is a very high prevalence of consanguinity. And there is emerging literature from some countries in collaboration with Professor Stephen Rohali's lab in Cambridge, who's done a lot of work on this area. We find a much larger prevalence of genetic or monogenic causes of obesity than what is reported in literature. Now, especially if you're looking at people who've had young onset morbid obesity with family history of young onset obesity with consanguinity, and especially if there are other features like hyperphagia, hearing defects, macrocephaly, visual problems. So then it's important to check for genetic tests, and we are able to do that in a cost-effective way with the next-generation sequencing platforms that are available. We recently did a study at our center, and we found that about 16% of these inclusion criteria having people have a genetic mutation. So the importance today is for this because we have newer drugs coming in the market. We talk of the MC4R agonist, a drug called setmelanotide, which can be used to treat people with mutations of the MC4R or leptin receptor, leptin, or even POMC mutations. So I think the context with respect to high prevalence of consanguinity makes it more relevant, though globally the prevalence for such causes is less than 5%.
Right, right. Professor Panel, what is your comment on the newer or the upcoming drugs for obesity management?
Well, I want to say that, in this particular case with this woman, she went through the Cushing syndrome, ended up still with obesity, severe obesity with BMI over 41, and then got the sleeve gastrectomy. We don't expect either sleeve gastrectomy or gastric bypass to get to normalize her weight. They're good, but they're not that good. And we now understand the mechanisms whereby the gastric bypass and the sleeve gastrectomy, how they affect their change on the body weight is by changing the peripheral milieu that then basically feeds back to the brain to allow the brain to be happier to lower body weight. And the medications we have now in America, and I don't know, the anti-obesity medicines at least that have been approved for use for weight loss, we have 4 of them officially. I don't know how many of them are available actually in India, but all 4 of them work in the brain to basically potentiate those signals coming in from the periphery. So in a sense, the medicines complement the surgical mechanisms to allow further weight loss. So all the current medications that are sort of in development that I'm aware of operate by mimicking those kind of peripheral hormones themselves, like a GLP-1 receptor agonist, semaglutide at a 2.4 milligram dose, which we don't have a name for yet, but looks like it's coming close to 15% total weight loss. In this particular case, you wouldn't think, because we believe that one of the mechanisms of sleeve gastrectomy and gastric bypass to affect weight loss is to enhance or boost the production of meal-related GLP-1. You wouldn't think that giving a GLP-1 on top of that receptor agonist would be of much benefit. But in fact, there has been a recent randomized controlled trial of patients who didn't do well with diabetes showing another 5 kilograms of weight loss or so. So they do actually have a role to play. There's also a combination of semaglutide plus a amylin agonist that is a combination drug that looks like it will have close to a 20% weight loss. And then there's a dual agonist therapy from Lilly where they combine a GLP-1 receptor agonist that's very potent with a GIP agonist. And I'd love to hear Dr. LaFerra's comment on that. I was kind of skeptical of that, but apparently the trials look like they have very good weight loss too. So the future will be with these more, with these drugs that are designed per our understanding of the physiology. We're not going to be just using medicines that were kind of discovered by accident to cause weight loss because they were used for something else, but they'll be designed and they'll be used in combination with one another. They'll be indicated by themselves, but we, of course, will start to use them in combination. But I'd love to hear Dr. LaFerra's thoughts.
Yeah, no, you did a great, review here, John, on all the, the possibilities. I think we're aiming towards some of the combination of those peptides that could be quite powerful. And I think we have also to envision the treatment of, I would call it common obesity, but maybe, 10 years from now with precision medicine, we'll have many types of obesity, of common obesity. But just like hypertension or even type 2 diabetes, we always use, when it's poorly controlled and we have, difficulty to control the sugar or the blood pressure, we have 2, 3, 4, sometimes 5 medications, each targeting, a different mechanism for type 2 diabetes. So it could be the same for obesity. We could target, insulin resistance. We could target the brain. We could target the gut, the liver. So I think those combination peptides are obviously something that we, the GLP-1 agonists have been a definite plus in the field. And we looking forward to have some other combinations of peptides, definitely.
If I might come back to some a theme we had a little bit earlier, I'm going to gently disagree with my esteemed colleague from New York City, in that when you have a disorder that approaches 40 to 50% of a population, and that's just the obesity part of it, a BMI over 30, at least here in Northern European, ancestry countries. Like other conditions like diabetes and cholesterol, we do have an expected first-line agent that when patients don't respond to lifestyle alone, we use them. Like diabetes, it's metformin. With cholesterol lowering, we have a statin. And I think because lifestyle has such a limited role, oftentimes, the benefit is a few kilograms long-term, up to 4% in the DPP, and Dr. LaFerre can comment on that. That, to achieve, especially in patients with obesity-related complications, or who are in the phase of what I call pre-obesity. So like we have a term for pre-diabetes before diabetes, or pre-hypertension before hypertension, and our focus is towards on those populations, much broader swath of the population now, but trying to really emphasize lifestyle. And what, especially pre-diabetes, we've moved towards recognizing that this is a downward trend that we actually need, a lot of them, to interfere with medications. Like lifestyle is very important, but with a medication like liraglutide, you can have lifestyle will give you a 60% reduction in diabetes progression, but liraglutide will give you an 80% reduction in progression. So I think, I think there will eventually be an expectation of a first-line agent for an anti-obesity medicine. It's got to be generic, cheap, available, and safe. And then the role of the more referral centers will be to manage the complex patients and the bariatric surgery in an interdisciplinary manner. So I'm sorry, I went on about an editorial there, but I think that
good insight, actually. Right, sir. So this is it. We end my part of the case here. Thank you everyone for the great inputs on the case, Dr. Nitin, Professor Blandy, and Professor Panel. So I think I'll stop sharing now, and we can go to.
Yeah. Thank you, Dr. Kalyani, for that wonderful presentation. And I think
it's my presentation.
Running a bit late on our schedule. I quickly invite Dr. Aramide to please come and share your screen and present your case. I truly agree, it has been a great learning experience so far for all of us, and I'm sure for all our viewers from across the world. Dr. Aramide, are you able to hear us? Yes, will you be able to share your screen? Dr. Aramide, are you there?
we can see you now. Can't hear you though.
Yeah.
Mute.
Yeah, with the sharing of the screen, could it be done through the technique? Mr. Saurabh, can you share the screen for Dr.
Yes,
Aramide?
sir.
All right.
I think, Dr. Aramide, your voice is better without the video.
Can you hear me, please?
Yeah, it's better now. Yeah, sure.
Right. Yeah. Thank you very much for this privilege. I'm happy to be in the midst of great minds. Yeah, I'm Dr. Aramide from Adediran from Lagos. I'll be presenting a patient with obesity. Can I have the first? Can you give me the first slide? Good. So I'm presenting a 22-year-old woman. who presented for an evaluation of amenorrhea of a duration of about 4 months. She also had a history of irregular menses 1 year prior to the onset of amenorrhea. Second slide, please. Second slide, please. Okay, good. Can you hear me? Okay. She volunteered a history of excessive hair growth in her chin, which warranted regular shaving. She also noticed that she gained about 33 kg within that year that was corresponding to the period, when she observed that she was becoming hirsute. However, there is no history of the use of anabolic drugs. She didn't have any use of synthetic progestin, neither was she on glucocorticoids or epileptic drugs. There was no history of headache, no history of increase in size of hands and shoes. Next slide, please. She had no history of hypertension, and there was no history of diabetes mellitus in this patient. There was no history of cigarette smoking or alcohol ingestion. She attained menarche at the age of 10 years. Next slide. She is the only child in a monogamous setting. Her mother is not obese, neither does she have a history of hirsutism. Next slide. On examination, let's talk about the examination findings. I found a young woman. She was not ill looking, but had a terminal hair on her shin and her legs. Her weight was 105 kg and her height was 1.75 meters. We got a BMI of 34.2 kg per meter squared. Next slide. Sorry for the next slide. Sorry for the typographical error. Her pulse rate was 76 beats per minute, was regular, good volume. She had a BP of 116/70 millimeters of mercury. She was not hypertensive. Heart sounds was just 1 and 2 only were heard. She had on abdominal, she had centripetal obesity with a waist circumference of 100 centimeters. There were no palpable enlarged organs, abdominal organs. Her chest was clinically clear. Next slide, please. I made a differential diagnosis of stage 1 obesity with metabolic syndrome in a patient with PCOS, polycystic ovarian syndrome. My second differential was Cushing's syndrome. The third, hypothyroidism. And the fourth, testosterone secreting tumor and acromegaly. Investigations done on this patient. Next slide, please. We had a pregnancy test done, which was negative. The fasting plasma glucose was 106 milligrams per DL. 2 hours postprandial was 116 milligrams per DL. HbA1c is 5.1%. Next slide, please. Her prolactin was 14.3 nanograms per DL, which was within normal range. LH, utilizing hormone, was 23.02 milliunits per mil, which was high. The upper limit of normal was 14.7. Her FSH, follicular stimulating hormone, was 7.2 milliunits per mil and was within normal range. But if you notice, the LH-FSH ratio was approximately 3:1, which is high. Okay. Her progesterone was 4.45 millimoles per liter, which was low. Testosterone value was 49.5 micrograms per DL, which was within normal range, 5 to 55 normal range. Estradiol was 61 nanograms per mil, which was also within normal range. At T3 was 4.2 nanomoles per liter, which was within normal range. T4 was also within normal range at 24 nanomoles per liter. Next slide, please. We had a transvaginal ultrasound scan done on her, and the findings are thus: the right ovaries and the left ovaries were 1.4 mils, 1.41 mils, and 12.39 mils respectively. There are multiple follicles greater than 12 in both ovaries. They surrounded the both ovaries peripherally, and each of the follicles were ranging between 4 to 9 millimeters. Next slide, please. Sorry. Other investigations: she had a 24-hour urinary free cortisol, which was less than 3.5 micrograms, which was, of course, the normal range was 3.5 to 45, so it wasn't significant. Her echo, she had an echocardiography done and no abnormality was discovered. She had lipid profile done. Her high density lipoprotein was 41 milligrams per DL, which was low for her as a female. Her LDL was 142 milligrams per DL. Her total cholesterol was 205 milligrams per DL, which was high. Her triglycerides was 125 milligrams per DL. Next slide, please. Next slide, please. Now, how did I manage this patient? We had to give her a lifestyle modification, exercise, dietary control, modifications, and she was placed on metformin 1 gram twice daily, and she was also placed on combined oral contraceptive pills. Thank you very much. Hello?
Yeah, thank you very much, Ramade, for that presentation. A very common case, I would say, in clinical practice. If I may invite comments from our chairpersons. Professor Blanton first.
Sure. Well, thank you. That was a very clear presentation, and indeed a very common, presentation. So I would probably have been a little more aggressive into the differential, just because, again, PCOS tend to leave in the back burner, but I want to make sure I rule out everything else. So you have a very negative 24 urine cortisol, which is very reassuring. So now, this being said, there are some very rare cases of intermittent Cushing. So I would probably repeat, perhaps some cortisol investigation. I usually want to have 2, or if I have a high suspicion of Cushing or a significant suspicion, I would do 2 or 3, repeat, within 6 months or a year, just to make sure. So like a morning cortisol and a DEX, suppression test, for example. Okay, so that's for that. Another thing that came to my mind, looking at your case, is that, the amenorrhea, the hirsutism, we should probably think also of a late presentation of congenital adrenal hyperplasia. This is not, unheard of. Sometimes they have partial, blockage. So they could present late in life with infertility or amenorrhea. So I would probably also look into that direction again, just to be sure. Now, the treatment might not be different than what you propose to this woman. And again, I will probably also do a 24 diet recall and check for alcohol intake. But you did mention that this was not part of the picture. So I'm going to stop here for my comments. The other chairpersons have some to add.
I agree completely, Dr. Blandine, with your thoughts. Whenever I see someone who develops either oligomenorrhea or amenorrhea in the setting of obesity like that, you have to go back, I think, to the original onset of the period of the menstruation. Were they regular at that time or irregular? And if they're irregular at that time, then you have that differential, of the PCOS, which is a steroidogenesis defect in the ovary, where there's an overproduction of androgenic steroids, versus the congenital adrenal hyperplasia. They're not fully penetrant as you but if they're irregular from the beginning, then that's when you think of those things. And then if they're normal and then they become oligomenorrheic or amenorrheic later, accompanied by weight gain, then what that typically is a very poorly defined condition in my mind of obesity associated menstrual irregularity. And there's a number of reasons why that might happen. As Dr. Blandine said, it could be Cushing syndrome, as you rightly look for as well. We know with patients who develop the phenotype of PCOS later, where they have the oligomenorrhea accompanied by weight gain, the insulin resistance that accompanies that weight gain leads to higher insulin levels. And it appears that the ovary remains insulin sensitive, even though the muscle and liver aren't. And insulin at the action of the ovary stimulates ovarian steroidogenesis of androgenic steroids. So there's also the possibility that the aromatase of the fat tissue itself leads to higher estrogen levels or gonadal hormone levels that then feed back and inhibit it. So the fact that her FSH and LH are kind of in the regular range, but you don't know where they are with the cycle, could be kind of a chronic feedback as well on that. In any event, whether you have, when you have that sort of weight gain associated onset of oligomenorrhea, then reversing the weight gain can really potentially benefit because it removes the insulin resistance, it removes the higher insulin levels, and can removes the aromatase effect, and you potentially could normalize periods in that regard. One thing that I was wondering was, did you have evidence of acanthosis nigricans on her exam? Which would sort of be a physical exam marker of severe insulin resistance. In which case, and again, you can comment too, what availability of anti-obesity medicines are there, in Lagos? What's the prevailing ideas about using these medications to help people lose weight in that regard?
Dr. Aramide, if you could unmute yourself.
Hello?
Yeah, we can hear you.
Okay, you can hear me. Sorry, I wanted to comment. The patient actually didn't have acanthosis nigricans. That was a positive negative. And when it comes to obesity, we have quite a number of people, especially the females, that are obese. And the use of anti-obesity drugs, I think a lot of them shy away from it, really. My patients shy away from it, possibly, especially the orlistat, because of its side effects, usually. And again, we have to consider costs. A lot of them think about that.
Sure, that's important. But along the lines of what Dr. Blandine was saying, level, just to sort of move that out. Dr. Nidden, what do you?
Yes, completely agree with what you said. And I would just like to add two small points. One would be regarding the test of TSH. Now, I saw in the investigations that only T4 and free T4 or T3 was checked. But I think in such a phenotype, we want to rule out primary hypothyroidism. So it is the TSH that should also be checked, and that was not there.
Yeah, I actually forgot to include that. The TSH was normal. I omitted that mistakenly.
No worries.
The
Yeah.
TSH.
And the other thing in the differential diagnosis, we had the exhaustive list, but then I think prolactin or hyperprolactinemia, though it was tested later on and it was negative, prolactin is normal, but I think it could be included in somebody who has amenorrhea for months who had regular cycles before. Hyperprolactinemia and its causes should also be included in the differential, clinical differentials. Yeah, so that's my comment on it. So are there any final comments on the case, Professor Purnell and Professor Pandey?
It certainly is a common scenario, becoming more common as the weights gain in the population. Here in the States, women are putting off pregnancy for later dates, which is, fertility is always something that comes around eventually to a lot of people's thinking. And as we talked about before, incidences of overweight and obesity just climb as we get older, peaking at age 60. So this convergence of later desire for pregnancy, putting off pregnancy till later dates, along coinciding with this unwanted weight gain that people are experiencing anyway, is creating a big, I won't say, I guess, issue around fertility. And so, as Dr. Blandine was saying, really emphasizing improvements in lifestyle in the pre-obese state is very important. And our biggest challenge, I would say, across the world, how do we counteract the forces of marketing for, fast foods and into the market, into the snack foods and things like that are very desirable? How do we allow people to remain active, even though technology makes our lives easier, and we kind of associate driving cars with, desirability when we should be walking and things like that? How do we design our cities? So, today's discussion, at least has been around how do we manage it once the obesity has manifested itself. But our bigger challenge as providers and the medical community is working with our colleagues in city planning and the food industry to prevent it in the first place. And we could, as Dr. Blandine said, we could have entire conferences just around each one of these separate ideas.
Yes, completely agree, sir. And that's a matter of great importance that has to be taken over, not only by health professionals, but even policymakers need to look at it in greater detail. So thank you, Dr. Aramide, for that wonderful presentation. And I think with this, we do come towards the end of this wonderful webinar. We've learned a lot. We've learned about management of endocrinopathies associated with obesity, morbid obesity, pre and post bariatric surgery, and common cases like polycystic ovarian syndrome. We've also learned about the newer upcoming drugs. The future does look bright, as Professor Purnell mentioned about drugs like GLP-1, GIP agonists, like tirzepatide, cagrilintide, coupled with semaglutide, CagriSema. Those kind of drugs are coming in. And so the future does look bright. And before I close, I would request our chairpersons to give a final word about the session and their final words to all our viewers. Professor Blandine first.
Well, thank you very much. I think this was a great opportunity to meet colleagues from around the world. So again, thank you for the organizers, for the technical support. In the old days, cases were discussed, locally and at grand rounds, and we still do that, of course. But I think here, hearing that across the world, problems are actually extremely similar, even if the cultures and the healthcare systems and the social network are probably completely different. So I think this is extremely instructive, and looking forward to more of those webinars. Thank you again to all the presenters also. That was very interesting presentations.
Thank you so much, ma'am. And the final word, Professor Johnson.
Oh, not the final word, but I echo everything Dr. Blandine said. Thank you to the organizers. Thank you to Dr. Nitin for working with us today. Thank you to the presenters. Very interesting and cases, and I really appreciate the discussion and the opportunity to have this chance to kind of share our experiences. It's really remarkable to think that we're doing this. Final plug, the Endotext website was begun by Dr. de Groot with a goal of providing knowledge at the level of an endocrinologist for free, as you would see in major textbooks. So please utilize the resource as much as you can, and hope that as we update the chapters, this information we're talking about today and other future resources will be available to you as well. So thank you for putting this on. It's a really wonderful opportunity.
Thank you, Professor Pernell. And as we started talking about it, I think this is one of the key good side of COVID-19 that we've realized, as Professor Landon was mentioning before, that this is a new way of living with being able to discuss across continents and get expertise on board. Thank you so much, Dr. Kalyani and Dr. Aramide, for your wonderful presentation. Thank you, Saurabh and Tech Support team. I'd like to thank Professor Sanjay Kalra and Professor Rakesh Sahai for organizing these webinars and coordinating with Professor Finn Gould in the US and all the Endotext faculty who are taking part in these webinars. Thank you so much, and have a good day, good night, and good evening, wherever you are. Thank you. Bye-bye.